Michelle, thank you so much for joining us on the You're Not Alone podcast today. I'm super excited to have you on. There were a few things when I was reading through your bio and some of your expertise that I'm really, really excited to talk about. But I think you, just like so many people in the OCD space, you have a connection to OCD that is personal. And so I'm wondering, can you walk us through your journey of living with and then eventually being diagnosed with OCD?
Absolutely. And I just want to also say that I'm happy to be here, and it's such an honor. And this is actually one of the reasons that I do the work I do today, because I can advocate and help a lot of people out there that might be struggling with similar things. So thank you for having me on it.
Of course.
But to go answer your question, I can give you a little brief overview of my history with OCD and the questions that you had asked. So basically, for me, OCD had started when I was 15, and I can remember actually exactly when it started. I was 15, and it was a couple months after a breakup with my first boyfriend in high school.
Yes.
And as you know, at that age, it's devastating, right? To have your first boyfriend break your heart, right? So I remember the symptoms.
Love.
Yeah, puppy dog love, exactly. So to me, that was a big loss and very devastating.
Yeah.
So a couple months later, I started developing some anxiety, some thoughts that I thought were really strange, and I really couldn't understand why I was having some of these thoughts. And I remember going through a really tough time, and my mom actually taking me to see a therapist, and the therapist actually diagnosing me with something that was not OCD.
What were you diagnosed with, out of curiosity?
So I was diagnosed with depression, actually.
So that, common misdiagnosis.
Right. Yeah. And I was probably actually also depressed, but the reason why it was there was not for depression. It was because I was having a lot of thoughts of harm. Thinking that something, I was scared that I was going to harm myself in some way, which I knew I wasn't going to, but I knew that it was just more the thought that scared me. So I think when I was explaining this to the psychologist, I don't think she was very knowledgeable maybe about OCD. And that's the case actually in the mental health industry. There's not too many people actually that specialize in the treatment of OCD. So probably not to her fault at all, but I was misdiagnosed basically.
Yeah,
so
that's very common still to this day. Yeah,
it is. So at that time, I continued to struggle with it, not really knowing what these thoughts were in my head, and I would try to make them go away. And, eventually that one episode it did go away. As OCD does tend to do, it tends to wax and wane sort of throughout your lifetime. So anyway, that one went away. And then again, when I was maybe 18, 19, I had a return of some other thoughts that were different from those, related to harm, but towards, other people at the time. So I wasn't sure what that was. It was terrifying to me, not sure, what was going on. I was really worried about harm coming to the people I love mostly.
Yep.
So then it returned kind of with a vengeance at that point, and I still did not know what was going on. So I took it upon myself to do some Googling and researching, and eventually something just clicked. I remember reading something online. Dr. Stephen Phillipson is his name, actually. He's really great, and he has a lot of information out there on the internet, and he's a specialist in the field, and it just clicked. I was like, you know what, this is what I have. Yeah. So then I actually went to see him, and I actually started to understand what was going on with me, and I was diagnosed, and I learned how to do the treatment actually, and I can say that I really don't experience it much anymore. So that's kind of my story. And I learned, the skills, and I became a psychologist for that reason, because I wanted to help people with OCD. And I feel that I can really understand what's going on with them because I've been through it myself. Right. So it really helps me in my profession. And I feel like I'm living my passion, by doing that.
And I saw that in your bio, and I'm so happy for you. As anybody who has been on that OCD journey, because it's something that we have for life, and it's something that we have to learn to cope with. It's amazing to see people turn that pain into their purpose. And I literally just had somebody on yesterday where we were talking about that. And that's why I was so like, it brought a smile to my face when I saw like, you have OCD and you became a therapist to treat others, and that you're in your purpose every day. One thing that's really interesting that I did not expect or I just didn't know I was going to get out of your story, was the breakup correlation. So
yeah,
the exact same thing happened to me. It was like the puppy dog first love. It was my high school girlfriend. We tried to make it work going into college, and honestly, like to this day, I think that she's just such a great person, but I wasn't mature enough in the relationship to make the distance thing work. But when we broke up, I was in love with her though, but when we broke up, I was completely devastated. So it was all the symptoms of breakup that you described. Depression was definitely a part of it. Couldn't eat, couldn't sleep, blah, blah, blah. And as soon as I got over that initial, probably like two and a half months of like, okay, I'm eating again, I'm sleeping again. Cause like my mom describes me as an anxious kid, but growing up, but I didn't experience like really severe, intense anxiety that was like so noticeable and shocking that it like shook me at my core, took away my appetite. I couldn't sleep. I had racing thoughts until that breakup. And so it was like I felt the breakup symptoms, and then shortly after that, I started to have sexual orientation, intrusive thoughts. So I think it's pretty well documented at this point, but do you see with your patients that come in a correlation between going through something traumatic like a breakup, even if it seems as silly as like 15 and young, like it still does, it registers in the brain, it still hurts, you know?
Absolutely. And you know what? Everything is, like I say, little kids, little problems, big kids, big problems. But when you're that age, that's what's important to you, right? So even though we might be adults looking back, we're 15, it was so silly. At that time, it was the most important thing to us, right?
100%.
So at that time, that's the most important thing to us. Just like as adults, something else really big might be important to us, right? But to answer your question, absolutely. When there's a lot of times a traumatic event is a trigger, and you may not see actually the symptoms come out right away. You might see them come out months later. For me, it was like maybe 7 or 8 months later that I started developing those symptoms, you know? So yes, traumatic events certainly can trigger loss, right? A breakup is a loss. So any kind of loss, any kind of change, any kind of uncertainty, any kind of change in your life brings up uncertainty too. So that can be one. I remember being in college, I was graduating college, and that was the trigger. You know, there was change. There's now I'm in the adult world. I'm not a kid anymore. So more responsibility. So change and traumatic events. But you know what? It could even kind of come out of nowhere. It can come out of boredom sometimes. You could just sit there and be having a thought and, okay, where'd this come from? You know?
100%. And then people with OCD, that thought becomes sticky.
Absolutely. Right.
But there is something to be said about that correlation and in loss and in transition that activates these genes, because from the reading I've done, it's like the way I understand it, and I want you to correct me or piggyback on top of it or whatever else it might be, is that these genes are epigenetic and we have them. They're already inside of us. It's going to come out at some point.
Right.
It's just, what is it? What is the catalyst that sort of activates those genes?
You got it. Yeah, to piggyback off of that, there's something called the diathesis stress model. So what that says is that basically exactly what you said, that there's a gene, you have a predisposition in your gene pool somewhere to have this, right? And then usually there's some kind of triggering event that brings it out. So if you can think of it as like a cup and there's a threshold, there's like a line, it's halfway filled for that genetic component, but then the traumatic event happens and now it goes over that threshold. And there it is for the symptoms to come out. So so what you're describing is exactly that.
That's a helpful analogy. And what is that model called again for my listeners?
Diathesis stress model.
Diathesis stress model. Okay.
Yeah, and that's not just for OCD. That's really for any.
Okay, I'm writing that down.
It's a theory. Yeah, it's a theory, right? So it's for really any kind of mental disorder or psychological condition that can be applied. Thinking of it that way.
Now, I wasn't planning on going down this path right away, but I'm just going to ask now that we're on it.
Yeah, go for it.
And by the way, I loved the little kid, little problems, big kid, big problems, and how basically it's all relative is what you're basically saying. And that's
exactly.
It's super important, I think, for people to know too, because I think we can sometimes get so wrapped up in the guilt of, why do I feel this way? I've got such a great life, or this, that, or the other. And it's like, it's relative. It's
Exactly.
all relative. And then you've got the cup analogy that you use, where for some of us, that cup is already half filled. So there's just a catalyst that's going to come along and fill the cup all the way up, and we're going to experience those symptoms.
Absolutely.
Do you see this industry? So being a practitioner, being a licensed individual in the space, when did ERP come around as like the golden standard of treatment? And have we had a big innovation in the space since?
It's a very good question. So when it came around, honestly, I don't know, but I can tell you that when I was 19 and I looked it up, it was the gold standard of treatment already. Okay. So prior to
Do you mind if I ask
age,
what year? Do you mind if I ask what year that was?
Geez, you know what? I'm not good at math. Hold on. Let's see. I graduated in 2000, probably like 2002-ish, I think, is when I looked it up. Yeah.
Okay. So it was the golden standard back then.
By then it was, because I remember looking it up and doing the research and finding that it was the gold standard at that point. As far as when did it come out when did it start to be the gold standard? That not really too sure, honestly. It's a good question. I probably could do some research and find that out, but I
could too.
Yeah. But I know by that time it certainly was, from what the research that I've done. And there was another question I think you asked me. Right?
Just so like ERP was so instrumental in my recovery, and I want to dive into that. And I really want to talk about the person-centered approach and some of these other things that I know you use in your treatment model.
Right.
But have there been any other big innovations from like a pharmacology standpoint, other types of treatment that are working, a surgery? I mean, are we in the process of some sort of cure I'm just curious, like, because as somebody who lives with this every day, I'm like, I don't want that. I'm glad that there's more talk about it, but I mean, can we get to a point in society where it doesn't really impact anybody's life anymore?
I can honestly say that doing the work that I've done, it really does not impact my life anymore. I really feel strongly about that through the work that I've done. But as far as where are we with treatments, really the typical treatment is SSRIs still. The SSRIs, really a combination of that with ERP is still supposedly, the best. You'll get the best results through both. But also ACT, acceptance and commitment therapy, is also another type of treatment that is very helpful. And I use some of those principles in my treatment as well. I incorporate that as well.
That's awesome.
So acceptance and commitment therapy, ERP, and as far as medication goes, SSRIs are still the ones that are being used most frequently. I believe there's a lot of research continuing to be done through the International OCD Foundation. And I get emails all the time from Columbia University doing pharmacology trials and things like that. But as far as I know, I am not aware of any really new developments. I know they talked about something that could target glutamate receptors. So I think that might be still in the works. So I don't think anything's really come out of it quite yet. But also there actually are some other things being done too, like ketamine treatment. I'm not sure if you've heard about that.
Oh yeah.
But so Spravato spray. It's also a new, I think, medication that's being tried for OCD. So these are some newer ones that I think are still in the beginning stages. And I do have some people, some clients that try them. And I hear mixed results, like hit or miss kind of. Some people say, it's working well. And some people say, no, I really haven't seen much. Similar to the SSRIs and the other treatments out there, medication-wise.
And I really appreciate you saying that. I'm not a licensed professional. I'm somebody with a lived experience, so I really tiptoe that line. But I get mixed reviews because because of the podcast. I get to talk to a lot of different people, and I've been advocating for long enough period now where I feel like I have a decent body of conversations, and so. It seems to me that that's a general theme, like especially just medication alone, like therapy and meditation or medication in conjunction seems to be effective. But just for the individuals that just want to take medication to treat OCD, it seems like they don't really get the best results. Did you take medication
Agreed.
out of curiosity?
I did try, but I honestly have not noticed much success from it. I've tried a couple things here and there, haven't, personally seen much of a difference. Some people will say that they had, really great results from medication. So it really is so case by case. It's so dependent on the person and how their body reacts and metabolizes the medication. And, sometimes for OCD, you need a higher dose medication. So sometimes it's a matter of finding the right psychiatrist who knows what they're doing to prescribe the right medication and is knowledgeable about OCD, which is also something that's a bit lacking.
Pretty rare.
I think.
It's very rare.
It is. It is very rare. And sometimes people, you find them, they can't afford to pay, for those specialists. So it's a little tough sometimes.
So Dr. Andrew Huberman, the Huberman Lab podcast, if you've had a chance to listen to him, he's a neuroscientist out of Stanford, and he had a whole, like a 2-part, maybe it was even a 3-part series on OCD, but there was a recent study done where they basically did, it's like the classic placebo side by side. Here's the individuals that are taking just medication. Here are the individuals that are just doing talk therapy. And here are the individuals that are doing, I think that's the way the study was conducted. I was listening to this last year. So disclaimer to everybody, I might be butchering this. That is the way that I interpreted it, that there were 3 groups, one just taking medication, one doing ERP, one doing medication and ERP. And after the study, they found, definitively that both groups that did ERP fared much better than the group that just did medication. I can't remember what the results were between the groups that were doing ERP, but one was also taking medication. So just an interesting point to throw out there, that you have to do the work, and ERP is a part of that. And you say that OCD doesn't really impact you as much anymore. What does that mean for you? I'm curious, because I have my definition of what that means for me, but what does that mean for you?
So that's a really good question. And again, it's all relative and it's all a matter of your perspective, right?
Right.
So, do I get intrusive thoughts sometimes? Absolutely. Right. Yeah. Especially during high times of stress or anxiety. I could be walking down the street and get one. So it's not that I don't get, and that's going to work against you if you expect to never get intrusive thoughts again. Right. So for me, it's a matter of applying those skills that I know immediately, so that it does not interfere and take up too much of my day, time, energy. And, once you start doing that more consistently, you're just really much more able to dismiss the thoughts and not really do those compulsions that, as you know, feed the disorder, right?
Yes. And I call those micro exposures, which is just intrusive thought came in. We're going to just go ahead and address this right now.
Yeah, I like it. I like that word.
I'm going to teach the brain right now that this thought is just junk content. It means nothing. It has no significance.
Right.
And
treat it for insignificant, because that's what it is. You have to treat it that way, right?
Because it is. Yeah, to your point, it absolutely is. Do you, in addition, so we're talking intrusive thoughts right now, and I totally agree with you. I think one of the biggest reasons why I've recovered, and what I tell people all the time is, like, the goal is not to never have another intrusive thought again. If that's your goal, you have just doomed yourself to a lifetime of being stuck in the OCD cycle.
That's it. Yep. And that's where that acceptance part is such a huge part of the recovery is acceptance, right?
It is. Acceptance is, I always say it's acceptance, it's uncertainty, it's indifference, and it's agreement. Like, I also like to agree with my thoughts.
Yeah. Yep. I like that.
Do you experience anxiety as well? Is your anxiety separate from, like, do you look at the anxiety as separate from the OCD in your personal experience? How do you look at that?
So, we all do get anxiety about certain things. And then, so sometimes it could be OCD related and sometimes it could not be OCD related, right? So, if we have, let's say, a big presentation coming up and we're feeling anxious about it, it's understandable that that's a normal reaction, right, to what you're about to experience. But if it's an OCD related anxiety, that's where you kind of get really good at pinpointing what's OCD and what's not, right? So regardless though, I personally feel that most anxieties I'll treat it the same. So I work with a lot of phobias. I work with a lot of social phobias, people with fears of needles, general anxiety, lots of different types of anxiety disorders. And it's really treated mostly the same way, you know?
Yeah.
So it's really about not feeding it. But how do I deal with it is I really do apply some similar skills, you know, because even if you're worried about something tomorrow and you're ruminating, I still apply those same skills to help with resisting the rumination or delaying the rumination, whether it's something I'm worried about for work tomorrow or whether it's about an intrusive thought.
Could you give an example? I think that's a really good point. Can you give an example of how you would do that? I think a real world tangible example would help. Help me too, but the listeners as well. Yeah. I'm always trying to learn.
Yeah, no, I think that's a great question. So let's say, let's say I'm in a relationship and I have a fear of, well, what if it doesn't work out in the future? And now I'm really tempted to start ruminating about that a little bit, trying to gain certainty. Say I'm trying to gain certainty of what's going to happen in that relationship. Yeah. So when I get that, I kind of say, okay, is this OCD? Is this not OCD? Do I have legitimate reasons to question this right now? So what I do is I try to think, is it effective or is it ineffective to problem solve this? So if it is effective and it's something I really do need to figure out right now, like for example, I don't know, let's say I don't have my headphones for something I need.
Yeah,
and I have to figure out, I need to problem solve and figure out how I can get them right now. It's effective to problem solve. So I'm a little anxious, but I have to effectively problem solve that. Versus something ineffective is, okay, I'm working right now and I get an intrusive thought about my relationship, but this is not really the time to engage this right now. So I'm going to put this off until a later time. So what I do is I try to think, is this effective versus ineffective to problem solve right now or to give my energy to? And if it's ineffective, let's say like when I'm going to sleep, it's ineffective because I need to get sleep and I don't really think it's good to be ruminating right now. So maybe I'll put it off until tomorrow if it's a non-OCD thing that I actually do have to problem solve. If it is OCD related, this is not effective to problem solve at all. So I'm going to allow myself to apply those skills and sit with the uncertainty and take the risk of whatever it is I'm afraid of happening.
And is that the effective-ineffective model? Is that what you utilize to help break that rumination? Like, are you...
Yes. Yeah.
Like using a work example, like let's say you have a big something tomorrow, big presentation. You have this podcast coming up. Oh my gosh, I'm about to be on the You're Not Alone podcast.
Right.
I'm so excited and nervous. Right, because I'm such a big shot over here.
Yes.
And so the night before, to your point, you're in bed, you want to go to sleep, but you're ruminating. You're thinking about you're feeling a little anxiety, you're thinking about everything leading up to this podcast.
Right.
Using that example, how would you use the ineffective effective model, and how do you... That's
a good one.
Yeah, and are there any other tools that you use?
See, in that case, I would look at that more of like a general anxiety thing, right? As opposed to an OCD, right? Okay, so this is more of a general anxiety. So also what I think to myself in that situation is, again, going back to that ineffective effective model, is this effective for me to plan this out and think about what I'm going to say tomorrow? Is there anything I can do about this right now? Right. Yeah. So what I would do in that situation is say, okay, now is not really the most effective time to be problem solving this and planning. So what I'm going to do is I'm going to make a plan. I didn't really do this one. Let's pretend I was anxious.
Yep. Let's just pretend. I like this.
Okay.
This is a good example. Yep.
Okay. I have a break tomorrow from 10 to 10:30. So from 10 to 10:30, I will spend time planning out what I'm going to say, what I think may come up. So I have a plan of attack when I go into it, right? So I'm basically delaying the rumination. I'm delaying any kind of problem solving because I know it's not effective to do in that moment, because I know that I need to get sleep, and it's going to be more effective for me to get sleep and be on my game as opposed to be sitting up ruminating all night.
Totally. And do you see that it works really well? Because basically people are able to say, you're able to signal to your brain, hey, you're going to get time to problem solve with this in the near future. So do you see with people with generalized anxiety that it sort of lets them off the hook?
Yes, I see that being a helpful strategy. Again, that could be used with anything that we're finding we're having some trouble with. Even OCD, yeah, exactly. Yeah. Because there's a lot, as you know, there's a lot of rumination that goes on, a lot of analyzing that goes on with OCD. Even social anxiety. There are people replaying social situations from the day, and they're trying to gain certainty on what happened in that conversation, right? Yeah. So with any type of anxiety, rumination is a big one. So I developed something called I call it a worry time. You may have heard this before, right?
Yeah.
Or sometimes I call it reflection time. So that okay, you're going to have a chance to think about this, but just not right now. So and then during that reflection time, you can reflect on this. You can problem solve whatever you need to do, but let's keep it at a time limited basis so it doesn't affect our whole day. So again, I'm using that example. You got a break tomorrow at work from 10 to 10:30. How about we make that your reflection time where you can kind of think about these things and solve these things a little bit more if you feel like it's something worth solving.
I really like that too, because I think, before TVs and modern technology, I think a lot of people, they journaled, like even,
yes, right.
Being a man, I know that it's not, every man's going to look at it a little different, but I think a lot of men would look at journaling as not very masculine.
Right.
And yet not too long ago, I feel that that's what men did. They sort of sat with their thoughts at night, and that was them getting out their ruminations and their reflections from the day onto paper. So that I think that I love that worry reflection time concept. I think that that's really beneficial.
Right. And actually, kind of going back with what you said about before bed, there actually is another strategy called like a thought dump, I guess you can call it, where you journal, you do the things that you are worrying about, that you're processing, that you know are going to keep you up. You actually spend time journaling before you go to bed. You get it all out on paper. That can help release that urge to be thinking about it all night. So sometimes that works well for people too.
I'm going to actually do an experiment with that. I've just made up my mind.
Yeah, let's give it a shot.
I sleep pretty well at night for the most part, but being an entrepreneur, and there's a lot of uncertainty around that. So for people with OCD, I will tell you, I've always wanted to be an entrepreneur. It was something I did my whole life. I wouldn't say it matches up 100% in terms of, I guess in a sense, maybe it's an exposure of learning how to live with uncertainty. One other question. So anyways, I guess I'm going to do this thought dump for a month, just at night. I like that.
I would love to hear about if you have, how it goes.
Yes, I will. I will keep you posted. One other thing with the example, like let's say somebody's sitting down and they're working at their laptop, or they're a student and they're trying to study for an exam, and they have that intrusive thought about, does my girlfriend really love me? Does she really care about me? Or does my boyfriend really care about me? Does my partner really care about me? And they do the effective-ineffective. And they decide it's not effective right now to ruminate on this. And they go back to their work, but it's still just there. As you know, as two people here talking that live with OCD, we don't get to easily just say, blow the thought away and we'll deal with you later. So what do you suggest on that?
That's a really good question. So, and I'm sure you probably learned this a little bit through ERP too, right? So we can't control our automatic thoughts. They're just going to come, right? Yep. So part of that is accepting the presence of them being there, right? So what happens is sometimes people get really wrapped up with, well, now I'm not going to study at my best. Now my attention's not going to be fully on what I'm doing. And part of that is you have to accept it because you can't control whether a thought's there or not. You can control not engaging it. You can control not analyzing it further, but you can allow it to kind of just sit there. And it's going to, if it keeps poking at you, okay, because that's a part you can't control. So you can just kind of notice it almost like you would notice a cloud in the sky, right? And again, I know this is easier said than done. It's a skill, just like anything else, right? But you're going to notice it. You're going to accept it being there. You're going to be okay with it being there. You're going to accept it poking at you while you're doing your work, because that's a part you can't control. So you're just going to allow it to kind of sit there while diverting your attention on your work that you're doing, and just accept that you may not be focused as much as you would be if that thought wasn't there. Because if you don't accept that, you're going to become really frustrated, and then it is going to overtake what you're doing.
How does somebody start to get reps with that? Is it basically just starting to just say, okay, I know that I have this intrusive thought that it just keeps looping, and I'm not going to do formal ERP right now because I'm not in that environment for this.
Right.
I guess it's just a deliberate decision. I mean, I know what I do so I agree with you, but for the person who's listening, it's like, okay, how do I actually do that? How do I just accept that I'm going to do my work while this is running in my head? Right.
Well, that's where kind of practicing ERP comes into on a daily basis, right? So, for example, if let's say that's an OCD related fear, right? That your boyfriend or your girlfriend doesn't love you or is going to leave you. doing something on a daily basis will help with that, right? Will help you to accept it, right? Because we don't just accept things, we have to practice it. We have to basically gain a tolerance for the uncertainty of those things. So through ERP and practicing ERP every day, that's how you build a tolerance to the uncertainty of your fears, right? So maybe the exposure that person might be doing on a daily basis is, I don't know, watching a clip from a TV show for a couple minutes, a couple times a day, where the boyfriend left the girlfriend, doesn't love them anymore, and they're sitting with the uncertainty of that happening to them. So maybe by practicing that on a daily basis, for example, they're building tolerance to the uncertainty of those things that they fear. So when the thought is there while they're doing their work, okay, this is nothing I haven't been exposed to 3-4 times today already. I'm going to let that thought just kind of be there and sit there while I'm going to do my work.
That's a great example, Michelle. That's a really good, tangible example. I appreciate that. And I think that you're absolutely right. The ERP reps matter. So I think this is a good transition in the conversation. I want to ask you about your person-centered approach to treating OCD. What does that mean?
Yes. Okay. So that means that I am considering always what's best. I mean, I'm sure most clinicians do this as well, but considering what's best for the client. So I'm always going to encourage them to do what's best for them. So for example, let's say they had something going on that day that really stressed them out, and they want to talk about it and they want to do some talk therapy. We're going to do that. Even though we're here for the OCD, what happens is I feel a lot of OCD therapists do is they have a very rigid, structured plan to therapy. So, okay, this is what our plan was to do. We're doing this, we're doing this exposure today, and this is pretty much it. So I don't really do talk therapy. We're just going to focus on that. So I would say the person-centered approach is being flexible, kind of thinking about what's best always for the client and what their needs are in the moment. And sometimes we do need to process those stressors that are going on throughout the day, because that is impacting your OCD at the end of the day too.
Yes. Yes.
So even I also do, I think it's more just for me, person-centered is about being flexible and having the client have autonomy too. Yeah. In what it is, it's a collaborative approach. It's not just me telling you what to do. Here's what you're supposed to do next. It's let's talk about this and see what makes sense for you. How do you feel that this exposure was for you? Does it feel too difficult? Does it feel moderate? What does it feel like for you? How do you feel about moving up? It sounds like you're doing pretty well. It sounds like you're feeling ready to move up, but you tell me how you're feeling. You make the choice. So I really I will express what I think is best for them and have them ultimately, just make their choice, and giving them a lot of autonomy, me being flexible, and working with them.
I feel like that creates it's a collaborative approach. You feel like a partner in the process versus like this expert that's sitting there fixing the other person. Something's wrong with them. I've got all my shit together and I'm here to fix you. So you just need to listen to me. Right. Which oh, sorry. What were you going to say?
Oh, no, go ahead. No, you go. Go ahead.
You sure?
Oh yeah.
Did you have a good point to make? Because if you have something good to say,
okay. I was gonna say that. So I was gonna say the other part of that person-centered approach is also bringing my experience into how I've done it. So there's something called self-disclosure, right, with therapists and psychologists, knowing when is it appropriate to self-disclose and when is it not, because we're not making it about us. But if I feel like it's something that maybe I've experienced that might help the person that I'm treating, I will share my experience. So that's actually a big part of it too, that person-centered approach.
You literally read my mind. That was the question I was going to have, because one thing that I have found absolutely fascinating, generally speaking, inside of the industry is this really, it sounds like you don't have a rigid approach, but this very rigid approach to like self-disclosure. And yet studies have found that like that relatability piece is actually like so which is why peer support is like this emerging market where you can train people that live with OCD, and you can meet with somebody who has lived with OCD and they share their experience, and it's $25 to $50 versus $200 or whatever it might be. So it's a cheaper approach. And I'll be honest, in my therapy experience with OCD, my OCD therapist, I had two, They're world renowned. They were experts.
Right.
And they absolutely saved my life. But there was a very clear distinction. I'm the patient. I'm being treated. I know how to get you there. There wasn't a lot of like, let me open up and share with you. And I've always found that very interesting. Why is that?
Right. Again, I think it's back to what you said, that there is a very rigid way, about that for some reason. I think, we're taught that in graduate schools that,
Why?
It's not about us. It's about, keeping on the client. Well, because sometimes it is not appropriate, right? Sometimes it's a matter, and again, it's a matter of knowing when is it appropriate, when it's not. It's appropriate when it's actually benefiting and helping the client in some way. It's not when it becomes like we're becoming the center of the focus. But I think there's maybe some anxiety for clinicians they're scared to go there, to maybe they might do something wrong or share something not supposed to. Maybe that's what's going on, Okay. But I think that could be it.
For people listening, can you give an example of when it's not helpful? Because they might, not all therapists are made the same. You seem like you are absolutely great. You've got a person-centered approach, which I absolutely love. But there are some therapists, I hear a lot people say, and I think that this is a little bit of a stigma, but I've heard a lot of people in my advocacy work be like, sometimes I feel like therapists are just trying to work their own problems out with me. So I've heard that, and I'm like, okay, time out. Let's have some dialogue about that. But I'm sure to a certain extent that there are some therapists that they do self-disclose at a level that's not beneficial for the patient. What does that look like? What would be a trigger for a patient to see?
I'll give you a good example, maybe between, a difference. So let's say there's a therapist let's say they're in a relationship, and something that their client is telling them about their relationship is kind of triggering the therapist, right? So like maybe they can relate, maybe they're in a relationship similar to that. So maybe they're asking the client questions about their relationship to see if they're in an unhealthy relationship, for example. So it's really, the benefit is going towards the therapist, right? So it's almost like a selfish based conversation. They're doing it for their own benefit, right? So that would be an example of it not being appropriate. But let's say that same thing, let's say there's the client's talking about the relationship, but let's say the therapist was in one in the past, maybe that was unhealthy, but they shared what they, maybe their experience and how they overcame the situation, or maybe they found something helpful that they did that matches up and lines up with the client's goals, then that would be really for the client's benefit.
That distinction was super helpful, because actually the key thing that I'm going to pull out there, the theme is that in one example, the therapist has processed through whatever that trauma or challenge was, and they have come out the other side of that, and they've gained tools and skills and perspectives that are now have helped them, that they can help others. The other one is like, I'm in the middle of this right now, and I haven't worked through this, but now I'm going to dump on you.
Exactly. And it's really, again, goes back to what's best for the client, right? So in that situation, how is that best for the client? It's really not. It's what's best for you, right?
Okay.
Or sometimes, like I work with kids and I work with teenagers too. And sometimes the teenagers will say to me, "Oh, I really like working with you because you told me that you really like red Mustangs," or something, right? And I actually have a red Mustang, but because awesome. They like cars, and we were building a rapport. But, my other therapist wouldn't tell me anything about them, So, but, that benefits me telling the client, because it helps us to build a rapport, right?
Right.
So I'm not saying that because I feel like talking about myself. So it's really about what's the intention, behind your self-disclosure. That's important.
Definitely. So you definitely do you believe in getting to know the client at a slightly deeper level than in your work?
Absolutely.
Okay.
I think you have to, especially if you're doing ERP. And as you know, it takes a lot of trust in your clinician, right? That you're exposing yourself to your deepest, darkest fears. You probably should trust the person a little bit to do that, right?
100%.
Yeah.
I mean, it's some of the thoughts they're so at first they feel so terrifying to share, but then you realize, oh my gosh, literally everyone with OCD, like depending on what your subtypes are, like we're cookie cutters of each other.
Yeah, exactly. And it's scary and I actually will say that, I know that how hard this is for you to talk about these things, and they're really scary. But I do spend a lot of time building a positive relationship, building rapport, building that trust. I think it's so essential and crucial, just like with any therapist-client relationship.
How did you open up to your family about having OCD?
So it was hard, I think, for them to understand at first, like, what's that, or how, or, I'm not really so sure that they quite still do understand, right? And that's okay.
Yeah. I sort of feel the same way.
Yeah. I didn't really go into too much detail about the nature of the thoughts and what they mean or this or that. But I kind of just, honestly, I did a lot of my own. I was very independent with the process, just because it's nobody's fault. I just think it's hard for sometimes people to understand. Like, if something doesn't make sense, they're like, why are you worrying about something? It doesn't make sense. Like, I know it doesn't make sense. I know it's not rational, but that's how anxiety is. So, I opened up just kind of telling them, like, I figured out that this is what I have, and I'm going to go get, treatment for it. And they were very supportive, of course, and they helped pay for the sessions and whatever you need to feel better. I'm not so sure that they quite understood it, but they were very supportive with me getting the treatment and doing what I needed to do to get through it.
So my family was very supportive too. I still feel, and my mom listens to every episode, so she's going to hear this. Mom, I love you. Yes. I love you so much. She was such a huge part of my recovery journey. But I do feel that I don't think that, like, outside of my wife, I don't think anybody really knows, like, what what OCD actually is and how you live with it. And that's why I wanted to ask you that. It's a hard thing
for people to understand if you don't have it. It really is. I mean, to everyone else's defense, I mean, it's not an easy thing to get.
No, it's, if you don't live it, it's, and even, but I love my wife so much because I feel like, because she's created such a safe space around it, that, like, she really knows it, but I think that's taken a long time. I do get from a lot of people, like, I want to share this with the loved ones in my life. Do you have any tips? So I'm curious, like, do you have anything that you recommend people do?
Yes, okay. Absolutely. I really recommend reading up on it, watching videos on it by people who are experts in the field. Because if you sometimes try to explain it, it's a little harder to understand, I think. So I actually work with a lot of family members on helping them understand. So what I do is I'll send them something to read. I'll have them watch videos. I'll actually do sessions with them so that they can understand it better and have them ask questions. So actually I would encourage them maybe to attend, as long as the client's comfortable with it and consents to it, but have them attend the session with the therapist to help them understand, because a lot of accommodating behaviors that family members do out of pure intentions works against the client's recovery too. So actually, I think it's very essential that they do understand, so that they're not enabling the compulsions too.
Yeah, and the other thing I'll pull out of that too is, it sounds like it's almost like offload that responsibility off of you, the one struggling with OCD, and provide resources for your loved ones, and say, hey, like, here are some resources that you can do your research and understand. I'm still learning about because especially OCD is so interesting in that it's like, you get diagnosed with it. I'm not an expert overnight. I'm still learning what the hell is going on with my brain too.
Of course. I always also say that if it's possible, I know not everyone can do this, but become, active with the International OCD Foundation. I mean, they really have such amazing resources out there. They have conferences every year. Anything that the family can do to help understand and support. They have family support groups, so anything they can do to become more of an active role in their therapy, I think would be really the best thing.
Okay. And then are there, you touched on this too, what are some of the pitfalls that family members can avoid in terms of, I guess the word I would say is like improper ways of supporting a family member that's struggling? You brought up accommodation.
Yeah. Right. So there's a lot of different ways it could be enabled, right? So reassurance seeking is one of them, right? So a lot of times the sufferer will go to whoever they're close to in their family and ask them, do you think this could happen? Do you think this is going to happen? Do you think it's okay that I did this? And a lot of times, it'll pull at the family member's heartstrings. Like, oh, it's okay. It's fine. Don't worry. You're fine. But that's not helping them to sit with the uncertainty, which is exactly what needs to happen in the treatment. Right. So for example, I'll give an example. Let's say we have a child with a moral OCD. Maybe they're feeling guilty about something. They didn't really do anything wrong, but maybe their OCD is telling them, hey, you did this wrong. You should go check to make sure it was okay. So then they'll go to the mom and say, hey, mom, I did this. Is this okay that I did this? And the mom might say, yeah, hon, don't worry. It was completely fine. There's nothing you did wrong, right? That reassurance then feeds the OCD, because it's not allowing that child to sit with the uncertainty, and becoming more tolerant of the uncertainty of what we're afraid of is what's going to help that child get better.
Yeah.
So that's just one example of, reassurance.
Totally. Yeah. And I think that that's a really good tangible example too of how not to accommodate if somebody is struggling. So I really appreciate that. One other thought that came to mind before we close things up. I see sometimes, like, on the chat rooms and stuff, like, I see, for example, like, a guy struggling with sexual orientation thoughts. Like, I distinctly remember this one recently where he was like, I got drunk and ended up getting head from some guy, but I really actually, like, now I'm confused, but I've always identified as straight with women. How do you navigate, as a therapist, how do you navigate a situation like that? Because I always go back to this quote by Brian Stevenson, which was like, there was a movie and a book. He's a civil rights lawyer down in the South, and he always says, nobody is as bad as the worst thing they've ever done. And what sparked in my head bringing that up to you is, like, with moral OCD, right? Like, let's say that somebody actually did something quote unquote bad or not socially acceptable. That one moment doesn't really define them, but they're so caught up in that as pointing to that proof as, like, well, this is the proof that I'm a bad person, or this situation happened, which is proof that I identified as straight, but now I'm gay, or this, that, or the other. So how do you navigate that?
Knowing that OCD will always take evidence from the past to prove its case of what you're afraid of, that's its MO. That's what it does. It's like a prosecutor trying to gain evidence to prove its case, right? So one thing that is important to remember is that OCD also, when people have OCD, a lot of times, not all the time, but a lot of times there's something called what we call perfectionism, right? So wanting things to be, expecting oneself to be perfect. So for example, in the case of moral OCD, nobody's perfect. We all do something that's probably not socially acceptable at some point. Maybe something that we would consider bad, right? Does this make us a bad person? No, right? So there's that tendency to go right to that black and white, that all or nothing thinking. And that's actually part of the work too, is doing CBT, right? To understand these unhelpful thinking styles that are also present. So just because I had this encounter where I got drunk and did something with the guy. But for the majority of time, I always, 95%, 98% of the time, I've enjoyed women, right?
Yeah.
When you have that black and white, all or nothing thinking, that one thing does not make me gay or straight or whatever it is that your orientation is, right? So I think a big part of the therapy is understanding those unhelpful, distorted thinking styles, and that, not overgeneralizing it. So understanding that that's a part of it, that's part of the treatment too, is recognizing that. And again, even if, you did do something in the past that could be considered unacceptable or could be considered disorientation, it's applying those same skills to sit with the uncertainty of them, right? Because a lot of times what I do for people is I'll have them write that down, write down what happened. So I was doing blah, 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 and I did this morally unacceptable thing. And they practice sitting with it and not ruminating on it, or not gaining certainty on it. So that's like an exposure exercise that can help with that too sometimes.
That was really helpful. I think that was a really, really helpful response, Michelle. And because I'm a male in the space, I get a lot of guys that reach out to me, and one theme that they seem to struggle with a lot is sexual orientation. And so
I work a lot with people with that. Yes, it's a tough for sure. And we experiment sometimes with, when we're younger, when we're teenagers, college, whatever. And I think that people need to normalize those experiences too, right? Because the reason why they're obsessing is because they're abnormal, right? They're looking at it as unacceptable and abnormal. So part of it is also normalizing it. as well, but not using that as a compulsion. So it's tricky.
Yes. And we're going to have to dive into that on another podcast, because I've thoroughly enjoyed having you on here.
Oh, I've enjoyed it too. Thank you so much. These are really such great things to talk. I mean, I could talk about this forever. So
me too. I love having these conversations. I've learned so much during this conversation. Let's conclude with this. I'm curious, what is one piece of advice that you would give someone who is right at the start of their OCD journey?
So that's a really good question. Really good question. So a couple tips would be just understand, be patient with yourself, right? It's going to take some time. So a lot of times when we're suffering, we want results now. We want to feel better now. So I think going into it with the expectation, being patient with yourself, that it's going to take a little time, not to give up right away if they feel like something doesn't work right away. Usually, sometimes with ERP, it is trial and error. Sometimes we have to figure out what's the best way to go. Like, I feel like ERP is an art. It's not just a standard structured approach. It's an art. So you have to work with your therapist on that art and figuring out throughout that process how to make it work, right? And what's the best way to go about this. So be patient. If there are you're going to have slip ups along the way, to not get discouraged and stop therapy because of that. And be compassionate with yourself, because it's not easy. And there are going to be times where you're not going to do everything perfectly. You may not get it right away. It's going to take some time. I would also involve, if they feel comfortable, involve the people closest to you to help with support. Because, it's always helpful to go through it with people than go through it alone.
It is. Well, and that's the title of my book right there. So you just tied that in perfectly. Well done on that one.
Right.
Yeah.
There you go.
And
that was an unplanned one.
I know. I love that. That was just a little plug for my book. I didn't do that
at 10 o'clock. That wasn't at 10 o'clock today at my break, I promise.
I slid a couple bills over the table to you there to say that. Yeah.
I got it.
Well, because for me, it was I think that's a really important point, because when I was first diagnosed, I was like, and I've had other people on the podcast who have OCD, and they're like, I'm not the only one. There's others.
Yeah,
it's like, there are millions of us. We're all over the planet.
It's so true.
It is. Yeah. I mean, there's millions of us, and I've had the pleasure of being able to speak to so many. And
that's wonderful that you do this. It really is.
I appreciate that. It's been fun. I get to have conversations like this for a living, and I'll tell you, the big thing. Amazing. I do see people they have a big fear of regressing or relapsing.
Yes. And I call that the feel better fear.
Yes. Oh, if I feel better, this must mean that XYZ is actually true.
Exactly. That's exactly it, right? Yep. That's the feel better fear. It's actually, believe it or not, OCD is very predictable, because most people have that one. Fear of relapse, fear of getting worse. When they're towards the end, when they've learned the skills and they're doing well, that's almost predictable that it's going to come in and do that one next.
I've had so many conversations with people across the globe now where I realize OCD is it's cookie cutter. We all have the same stuff. It's
just different content, different ways it manifests. Right?
Exactly. Yep. So
that's right.
Well, Michelle, you were a great guest. Thank you so much for coming on to the show.
Thank you so much. It was an honor, and thank you so much for having me. And I really admire the work that you do. So thank you for having me.
Yeah. And same to you. Big shout out for turning your pain into your purpose and giving back to those with OCD. That's awesome.
Same to you.
Awesome.
All right, Zach. Thanks again.
Thank you.
All right. Take care.